Hello everyone. In this particular video, we would be taking a look at polyhydramnios. So let's look at the definition first. Polyhydramnios is defined as an excessive accumulation of amniotic fluid, where liquor amnion exceeds 2000 ml, clinically diagnosed with when the amniotic fluid index exceeds 24 cm and the deepest vertical pocket is greater than 8 cm. So diagnosed when AFI greater than 24 centimeters or deepest vertical pocket DVP is greater than 8 centimeters. Coming to the etiology, the exact cause remains unknown in 60% of the cases. However, severe maternal and fetal factors contribute. So there are fetal causes, placental causes, maternal causes, multiple pregnancies and idiopathic. So let's look at each of them one by one. So coming to fetal. So congenital malformations forms a major section here, 20% of the cases. So anencephaly, excessive transudation from exposed meninges, open spina bifida, increased transudation from neural tube defects. So these are somewhat similar. This is on the spine level, this is at the head level. And this one, esophageal and duodenal atresia, prevents normal fetal swallowing of amniotic fluid. And facial cleft neck mass interferes with normal swallowing. Hydrops fetalis due to RH immunization, isoimmunization, normal hydrops fetalis, cardiac anomalies and torch infections, also parvovirus B19. So all of these things increase the amniotic fluid level. So let's look at the pathophysiology once. Pathophysiology, maybe it is there somewhere. No, it's not, because it is not there, is because it is not asked repeatedly. So of polyhydramnios. So we know already that that is not mentioned here. So I'll just explain it here. So the thing is, usually the amniotic fluid, it is being consumed by the fetus and also it excretes it. So any problem which prohibits the absorption, meaning not absorption, swallowing mechanism of the fetus, anything that inhibits it reduces the amount that is swallowed. So because of that, there is excess of such fluid which is not being consumed by the fetus. So because of that, there is excessive fluid in the sac. So that is what forms the main basis of polyhydramnios. So then going to the placental, that I just explained it just so that you are clear with this particular thing. Coming to placental causes, chorioangioma of the placenta, tumor with increased transudation. And then maternal causes could be diabetes mellitus and cardiac and renal diseases. Causes of diabetes mellitus causes fetal hyperglycemia, which causes fetal polyuria, which causes excessive amniotic fluid. So this one, it is clear. So the fetus is the one that is excreting it and the fetus is the one that is consuming it. So if there is excessive excretion of this particular thing, there is more of the fluid. Coming to cardiac and renal disease of the maternal side, impairs placental drainage leading to transudation. And finally, multiple pregnancies, increased incidence, especially monozygotic twins, commonly affecting the second twin. And then there are twin to twin transfusion syndromes, fetuses with TTTS. The recipient twin develops polyhydramnios. As we know, a lot of fluid, hypervolemia in the recipient twin. And then this one, idiopathic, causes remain unknown despite the investigations. Looking at clinical features, symptoms: respiratory distress due to pressure on diaphragm, palpitation, increased cardiovascular load, edema, swelling of legs, varicosities, hemorrhoids. So respiratory distress due to pressure on diaphragm, palpitation due to increased cardiovascular load, and edema, which is swelling of legs, varicosities and hemorrhoids. Coming to the signs: abdominal enlargement disproportionate to the gestational size, shiny tense skin over abdomen, and palpation findings: height of the uterus exceeds gestational size, because there is, so overall for everything, symptoms and signs, mainly because of the pressure effects. Abdomen feels globular and full. fluid thrill elicited over the uterus, and auscultation, difficulty hearing the fetal heart sound due to excessive fluid. So, as you can see, even over here, the pressure over the diaphragm, which is the pressure effect, so respiratory stress here, increased cardiovascular load, as we all know, it's lots of fluid accumulation, and also swellings everywhere. Yeah, then coming to the diagnosis. Yeah, so first one, sonography, and then we have biochemical tests. Sonography confirms amniotic fluid index greater than 24 centimeters or deepest vertical pocket greater than 8 centimeters. Detects congenital anomalies, fetal hydrops and placental abnormalities. And finally, monochorionic twin pregnancies, TTTS. So, these are the sonographic findings. Biochemical tests, alpha fetoprotein, elevated neural tube defects, glucose tolerance tests to detect gestational diabetes, and ABO and RH to identify RH isoimmunization. Coming to the management, finally, bed rest and maternal monitoring for complications, preeclampsia, preterm labor, and diuretics are not useful. COX-2 inhibitors, Sulindac reduces fetal urine output in unexplained cases. So, this is one drug which we have learnt right now. So, then coming to frequent antenatal visits to monitor fetal well-being, and coming to specifically the management, like that was general, this one is specific management. We have mild polyhydramnios and severe polyhydramnios. Deep vertical pocket 8 to 11 centimeters. So, what was the cutoff? 8 centimeters. So, 8 to 11 is the first level, and beyond that, there is severe, which is 16 centimeters. So, first one doesn't require much treatment, and severe polyhydramnios, hospitalization for high risk cases, and there is amniocentesis, removal of 500 ml per hour to relieve maternal distress, reduce the risk of accidental hemorrhage, and may need to repeat the procedure if AFI is still elevated, and corticosteroids to for fetal lung maturation if preterm labor is imminent. Coming to the management during labor, early rupture of membrane is common. So, therefore, we need to do careful monitoring. Avoid excessive liquid drainage to prevent cord prolapse and placental separation. Delivery, if greater than 37 weeks, induction of labor may be necessary. Caesarean section indicated for malpresentation, fetal distress, and multiple anomalies. So, these are the things which we need to consider. And finally, coming to the complications, there are maternal complications, fetal complications. So, here we know that it is like pressure effect mostly, and because of that most of the symptoms arise. So, there is preeclampsia, there is malpresentation, which is the fetal life being affected, and premature rupture of membranes, as we have seen earlier, and preterm labor, spontaneous or induced. There could be also risk of postpartum hemorrhage due to uterine atony. Uterus is not able to retract properly, and retained placenta and increased puerperal infections. Coming to fetal complications, perinatal mortality, mostly due to prematurity and congenital anomalies. Next, looking at finally cord prolapse, hydrops fetalis, IUGR, and increased risk of post-operative delivery. So, these are the things which we need to keep in mind when looking at polyhydramnios. So, these might look somewhat out of the order. So, but in case you would like to, you can stop the video right now, but for completion sake, I would like to copy this and just take a look as to why these are the complications for polyhydramnios. But you are free to close this right now, because I will be going through ChatGPT, because this was not particularly clear for me. Why in polyhydramnios? So, polyhydramnios increase uterine stretch leading to endothelial dysfunction, placental hypoperfusion, which leads to development. This one is making sense. So, excessive fetal movement preventing the fetus from settling into one place, which is cephalic, leading to breach or transverse. Yeah, this one makes sense. This one makes sense. Preterm labor, spontaneous or induced, uterine overdistension triggers contractions. Postpartum hemorrhage, after delivery, overstretched uterus struggles to contract effectively. Yeah. And retained placenta and puerperal infection. Distended uterus may have difficulty expelling placenta, increasing the risk of retention and infection. Fetal complications, perinatal mortality, prematurity, so that is one, and congenital anomaly. These are the risks that are associated mostly. Impaired swallowing, which is causing this. Cord prolapse, excessive amniotic fluid can cause umbilical cord to slip out during labor, leading to hydrops fetalis. Severe fluid overload can lead to hydrops fetalis, a life-threatening condition involving fetal heart failure and massive fluid accumulation, IUGR, in cases of placental dysfunction or twin-to-twin transfusion syndrome. Increased risk of operative delivery. Yeah, all of them make sense right now. So this was a very good topic. Yeah, so in case you like this particular video, you can like it. In case you would like to watch more of such videos, you can subscribe. Bye bye.